Hello and welcome everyone. Today we'll be discussing about continuous glucose monitoring systems in the ICUs. Now, dysglycemia in ICU patient is linked with increased mortality and morbidity. Standard glycemic control relies on frequent intermittent blood sampling, that is arterial or capillary, and insulin therapy. This particular thing is extremely labor intensive for the nurses. CGM, that is continuous glucose monitoring, has proven beneficial for OPD patients, that is in type 1 diabetes management. And this is being investigated in the ICU setting as well. COVID-19 pandemic accelerated interest in this because at that time managing the patients inside the ICUs was becoming difficult, so people were trying methods to remotely monitor most of the things. So this discussion mainly fuels from the fact that we need to monitor in the glucose level and titrate the insulin. So the main controversy started with the intensive insulin therapy, that is the IIT trial, in which Vandenberg in 2001 showed that in critically ill surgical patients, intensive insulin therapy, that is a glucose maintained between 80 to 110 milligrams per deciliter, versus a conventional, that is around 180. Uh, and the outcomes they were looking for was mortality and ICU complications. In this, they had a significant reduction in the mortality, decreased bloodstream infections, lower need for transfusions, and renal replacement therapy in patients staying for more than 5 days. But it was contradicted by the NICE sugar trial, which was a much larger and multicentric trial compared to the single-centered Vandenberg trial. It was a similar group of patients but contained both medical and surgical. The glucose level were essentially the same. They looked at mortality and they found more mortality this time with the intensive control because there were more incidents of severe hypoglycemia. But the problem here is people interpret this as a failure of intensive glucose control, and the blood target of 80 to 110 is somehow not good for the patient, but that is actually not the fact. The fact of the matter is the patients had complications because of the hypoglycemia and the required of that intensive management. In the Vandenberg trial, there was 1:1 nursing, for which the sisters were able to pick up the hypoglycemic episodes and they did not have those hypoglycemic episodes. However, in this particular case, because the nursing was as usual, not 1:1, because we don't get 1:1 nursing in all the ICUs. This was a multicentric trial with 1:2 to 1:3 nursing. In that case, the labor intensive glucose monitoring could not be done, which is quite practical. So in those cases, when we are targeting a blood sugar of around 80 to 110, then we are getting a more chance of getting hypoglycemic. So we are looking for methods where we will be doing this in less labor intensive manner. This is basically a review which has been published in ICM that looks to map the literature of the continuous glucose monitoring accuracy in ICU population to identify which types of CGM we can use and what the basic studies have been done and their comparators and how to do future trials. So first, coming to different types of CGMs that we have. The most common one is the subcutaneous. It is most commonly studied in the ICU. The sensor is placed in the interstitial fluid space under the skin and commonly requires calibration, though newer factory calibrated models are now existing. Accuracy can be reduced by changes in the tissue perfusion, shock state, and hypoglycemia. The next is intravenous. Sensor is directly placed in the vein, generally shows good accuracy, that better accuracy than the subcutaneous system, closer approximation with the blood glucose levels, and limited commercial availability and less clinical familiarity because directly venous monitoring is not a technology which has been so popularized yet that we have it so freely at the bedside. So it has limited commercial availability as of now. So for this review, they looked at the literature which is published in the PubMed and Embase, as well as Google Scholar was also searched. This included RCTs, observational studies, and various other trials on CGM. The data was extracted based on the population, the CGM type, the comparator method, the accuracy metrics, and the protocol for the referencing. 96 studies were included, which were conducted after 2013. Predominantly observational, only 8 RCTs could be found. Majority were adult ICU patients and mixed general ICU was around 50%. The CGM systems and the comparators. 80% used subcutaneous CGM, fewer used intravenous, and intraarterial 5%. The reference test varied: arterial blood most commonly 41%, but also capillary, venous, and mixed approach. Some studies did not clarify the reference source. Overall, the MARD ranged from 6.6 to 30%. The lesser it is, the more accurate it is. And the MARD tended to be lower for the newer generation CGMs, which is quite expected. And the Clark error grid typically was more than 95%, which is clinically acceptable. And the accuracy often decreased during hypoglycemia, and it is an important concern because this is the reason why we want to do the continuous glucose monitoring, because if we are unable to pick up the hypoglycemia episodes, the whole utility becomes a little problematic. Some improvement in accuracy has been seen over the years, but still high variability still remains. The intravenous is good, which is 5 to 14%, often better than subcutaneous. The intraarterial is equally good, 6.4 to 13%. The consistency is more than 95%, 99% here, which is extremely good for clinical accuracy, and limited clinical availability and fewer commercial options compared to the subcutaneous CGM. So though these methods are pretty good and very accurate and can be replaced at the bedside, but then their technology is not so advanced and so freely available right now, so that we will use currently at our bedsides. Regarding the hypoglycemia, again, accuracy is poorer in the hypoglycemic range. Some studies showed equal to better accuracy in hyperglycemia, but the data is quite mixed. Increased risk of misinterpretation when glucose is low could impact patient safety, because as I said, the whole purpose of doing the CGM in ICU is to prevent hypoglycemia and do an intensive insulin management. So many studies lacked a systematic protocol to check for bias. Structured references are not given. Hybrid approach may enhance the safety and all. So the clinical implication is the subcutaneous is the one which looks the best as of now for logistical reasons, because the venous and the arterial are not yet so advanced to be used at bedside in freely. The subcutaneous is improving, but still it is not really ideal as of now to titrate insulin based on that alone. Intravenous is pretty good and accurate and can replace, but then it is not yet technologically advanced to come at the bedside. So the potential role of CGM alarms and hybrid strategies to prevent hypoglycemia for high-risk patients is required. More robust trials are needed to confirm clinical benefit and cost effectiveness in ICU setups. So for future, standardized framework for accuracy assessment is required to improve the comparability. We must find out a method by which we can do the comparison. Focus on evaluating CGM performances across the all range, especially the hypoglycemia. Larger RCTs with factory calibrated CGM for decision making of the ICU insulin therapy is the point that we are looking for. Consideration of CGM implementation strategy that reduces workload of the nurses and improves patient outcome is what we are actually aiming for. So the take home message is CGM accuracy in ICU is variable. It depends on the device used, the comparator, and the glycemic range. Intravascular outperforms subcutaneous in accuracy. The newer subcutaneous are better than the old one, but they still need validation. Standardized protocol and reporting is crucial to ensure that we can compare the various studies. Currently, every type of comparison method is being used, every type of range is being used, and so we still can't really compare all the studies. Thank you for your patience.